Thank you so much, Theo. I'm really excited, a little bit nervous to be here, but we'll get through it. First thing, I really wanted to thank you, Theo, for the space, for joining so many like-minded people. And the UX healthcare conferences have been amazing. He said that I was at London last year, and it was truly inspiring to meet so many like-minded individuals who are passionate about UX healthcare. Um, if we haven't met before, my name is Maria. I am from Bogota, Colombia, and right now I live in Atlanta, Georgia. So it's nice and sunny out today. I'm very happy to be here, and I currently work at a company called Digital Scientist, and I work on the experience team as a design strategist. So today I'm going to walk you through a little bit of a case study that we worked on last year and that we're continuing to work on this year. So before I start, I want you to invite you to close your eyes for just a moment, if you can. And I'm going to guide your imagination for a little bit. Imagine it's a nice, warm summer day. The sun is out, and you're young. You're a toddler. You're maybe about 2 or 3 years old. And you're in front of this big, deep, blue swimming pool. You've never been one before, and it looks immense. It looks a little bit scary. Then, all of a sudden, you feel a big push from behind you, and you're thrown into the water. You weren't ready for this. You don't know what to expect. You feel overwhelmed, and fear really creeps into you. You feel unsettled, unsure, you don't know what to do. You feel distrustful of everything and everyone around you. Okay, I want you to go ahead and open your eyes. And I wanted to do this just for one simple reason. I wanted for you to experience, just very briefly, what it feels like to be thrown into the unknown, that discomfort, that fear, that sense of vulnerability. And no, we're not here to talk about pool safety. We're here to talk about these individuals, MDS nurses, and how they felt when a new AI framework was introduced into their workflows. They felt fear, skepticism, and distrust. And why? Because MDS nurses work in an environment that's filled with very heavy regulation, intense audits, and zero margins for error. One misstep, just one, can have some very serious consequences, not just for them, but for the residents that they serve, and for the facilities that they work for. So, how do you introduce this new technology for them in a way that earns their trust and doesn't build that resistance? So that's exactly what I'm going to talk to you about today. And I'm going to go through 3 main points. The first one is I'm going to tell you a little bit about the context, so we all can see the MDS nurses through their eyes. Then we'll cover the problem. So what exactly was leadership experiencing? Why did they bring in the digital scientist teams? And what happened for, in the past, other tools where they were trying to integrate AI felt really short. And finally, I'll go through the bridge framework, which is the canvas that we built after we learned and we tested different things to earn this trust with the nurses, as a conclusion and as a path forward, going from that fear to a lot of safety, trust, and collaboration. Okay, so very quickly, I want you all, if you can take one thing about the context of the MDS, is that it's 2 things. One, it's a very heavy form. It has a very big weight. And the second thing is I want you to think of an MDS almost like a snapshot of a resident. So an MDS form is a standardized assessment that's completed by MDS nurses. They do this within skilled nursing facilities or nursing facilities. And they track different things. So the snapshot takes a look at the resident's medical conditions, physical conditions, cognitive conditions, and their emotional. And this is all tracked under a model called the PDPM model. And this is data that Medicare uses um, to determine the payments, right? So care needs are measured by individual care needs and not by therapy minutes. This is important. And they do this, they take the snapshot within a certain time frame. That time frame is referred to as an ARD date. So they set that date up and they have seven days to fill in this MDS form that covers 20 different sections that track all those things that I just mentioned. Then this form goes to CMS, which is the federal agency that processes the MDS form and ensures that the standardized assessment is responsible then for the payment of these long-term facilities. So if if a resident needs more care, they will get higher reimbursement rates for the facilities. If they need less care, they're going to receive lower payments. And they also track another thing called the QM. So the QM, for everyone to kind of understand, is almost like a hotel star rating. So if you have a very good star rating in a hotel, that would normally mean you have very good amenities, the staff is great. Here, the CMS is tracking if these facilities are great for people to be in, but they're tracking their health conditions. So are these facilities ones that are preventing pressure ulcers or preventing falls for their residents? So when I talked about the weight of the form, the first thing I talked about is how long it is, but the other weight of the form is the consequences. So some of the consequences that nurses can experience if they fill out this form incorrectly or they miss a key date is the first one, and the most important one is not being able to give patients the correct care that they need. Then also having regulatory penalties. So if there's any errors, facilities can experience fines or loss of certain certifications. We also have financial risks. So maybe there are risks um, there are mistakes in coding or errors in the way that they've filled out their MDS assessment, and that can trigger very heavy audits and payment issues. And last, I just talked about it, we have that QM impact. So if a facility scores very lowly, this can also affect how people perceive them, but also the type of residents that they can have within these facilities. So one of the nurses referred to filling out the MDS form to us as a game of chess. They have to be thinking 3 steps ahead. They have to be very conscious of what decisions they're making, and they have to be very strategic at tracking the correct things. So to prevent these consequences, before the digital scientist team came in, what they tried to do is bring in AI to streamline decisions and surface insights to make it easier for the nurses to fill in these MDS forms. But, and this is a very big but, it didn't work out. So why didn't it work out? Well, first, the nurses didn't trust the tool. They trust their instinct a lot, and they're very, very meticulous in taking care of their patients. So when this new AI tool was giving them results, they weren't. It was going against their instinct and going against what they do and their human touch and their experience with their residents day to day. Next, it slowed them down, so it was taking much longer for them to fill in their MDS resident summaries, MDS forms. They want to be able to do this in a speedy way because they have to look after one MDS nurse can look after 40 patients. So they want to be able to do this at a good pace, but this tool was making them go back and forth and back and forth. And last but not least, it wasn't transparent. So exporting a lot of decision points, but the nurses didn't know where this information was coming from. So CommuniCare, which was our client, came to us with a very clear vision. First, they really wanted to simplify data verification. They wanted to be able to surface those predictive insights clearly. They wanted to help nurses be able to action in real time. And they wanted to make sure that they could reduce the risk and make timely decisions. And last but definitely not least, they really wanted to make sure that this fit into nurses' workflows. So then we had two very clear challenges. We really wanted to design with these goals in mind. But the second one, and the one I'm going to talk about today, was we really needed to rebuild the nurses' confidence to that skepticism that they already had from this disillusionment that the previous tool had caused. So what we thought as a team is this isn't going to be enough for us to build them the best tool. We really have to bridge that gap from no trust to trust. So we listened, we tested, we understood what worked and what failed. With what we learned from what worked, not what failed, we built a canvas. And this canvas is called the Bridge Canvas. Of course, it's an acronym for us to easily remember what we did that worked very well. And today I'm going to walk you through brick by brick how we crossed that bridge. So let's start with bring in the stakeholders and build together. So when we started in this process, we were able to contact a wide range of stakeholders. This was MDS nurses, MDS travel nurses, we had their regional managers, and we had the leadership team. And with them, we did contextual interviews. And from those contextual interviews, we built out a giant journey map. But we didn't treat this journey map as a fixed deliverable. We took it on site and we made a shift from having this static document to having this living and breathing document where we were able to co-create with nurses that experience the MDS process day to day. So we were able to listen and hear and see their real interactions with the MDS process. And this was really impactful for us to be able to do. The next big thing we did that really helped us gain trust with the nurses, and that I really recommend to anyone who is trying to build in AI or like foster this change for integrating AI into their systems or into their workflows, is we built together but in context. So I can't stress enough how much importance it was for us to be there in context. When we started this process, we felt like the MDS form, when they were filling it out, it was just like, I start my MDS form, I fill it in, and I close it. And it's not like this at all. We understood that there is one key moment within the MDS nurses workday, that is the clinical meeting. It is a daily meeting in the morning where all the people who are really advocating for their residents just go around and talk about how the residents' health is and how they are. And MDS nurses would take this information, also give out information from what they've seen in the past. And from those clinical meetings, they would come into their computers and type in all those changes already to have them for the next MDS form that they had to submit. So this is important to highlight, just because if you're not in person, sometimes remotely, we miss tiny technical details, and the risk is really framing the problem in a wrong way. So here's a question to consider is, have you involved a diverse group of stakeholders from the start, and have you observed their daily work firsthand? The next brick we have is eyes. And so this is a brick that I particularly enjoy, and it's recognized and reduced to what matters. So after we mapped out the journey, the leadership team saw 30 pain points, and they were really excited, and that's understandable. Um, and they really wanted to tackle everything at once, right? But instead, we recommended a more strategic path, which was to slow down and identify what matters and start small. So, how did we recognize what really matters and what these nurses were really worried about with all those pain points? Well, we asked a very simple question, which was, what is keeping you up at night? So, from that, we discovered that there were three main points in our journey that nurses were really worried about. The first one was the start. So, are they picking the optimal ARD date? In the middle, they had a pain point that was all around, am I able to see my patient's changes in health? Because as we know, a resident's health can change maybe over 2 days, or maybe this is going to be an hour change. Like maybe in the AM, they have full mobility, and in the afternoon, they don't have mobility. So, can I see those changes over time very quickly? And can I relay this information to my clinical team during our meeting? And at the end, we had, have I done all the checks? Am I missing anything in my MDS? So we decided to start with the middle. Why? Because it was a point where everyone converged. It was also a point where everyone was aligning in the status. And it was something that we were asked to do in the goals, which was to deliver real time decisions. So we had a framework of time and space to work with. And it was a quick win to build trust early on. So now I'm going to advocate to start small and really reduce to what matters. And the people who are on this call that know me are probably laughing or smiling because they're thinking, of course, Maria is advocating for the power of small. Because for the people that don't know me, I am very small. Maybe you can see by my tiny hands. But yeah, small is very, very powerful. And for us, it worked really well because we were able to get targeted feedback very quickly. We were able to show results early. We were able to build trust very quickly. We were able to manage that complexity that comes with integrating a new machine learning language model. And we were able to have this strategic momentum to keep going forward. So, why was this initiative small? There are three things that I want to highlight. First, we had that one clear touch point, which was during the clinical meeting. The second thing was we had one simple workflow, so that it was just that at a glance data to begin with. And the third reason why we kept it small was we had only 5 pilot nurses on this study. After this, of course, and validating that our first approach to the MDS nurses' needs, we were then able to scale to the next two big pain points that they had in their journey. So my question to you is, are you accurately framing your stakeholders' problems? And are you starting small to validate before you scale? Okay, let's move on to the next brick, and it's investigate what matters. So I talked about the start, the sense of delusionment that our client had already had. They had had low adoption and bad impact from the start. So it was very, very important for us to, from the start, have this impact and really define what success means. So we decided that it wasn't enough just to measure one time, but we continuously measured throughout a 8-week period, and we had milestones throughout this pilot study. So this really allowed us to understand our missteps very quickly, and it was an iterative approach to help us de-risk this process. So what did we really measure throughout the pilot study? First thing was, are we really reducing the nurses' times, or do nurses actually spend a lot of time going through additional data or additional software instead of looking at the MDS resident summary? The second one was, did this solution streamline their workflow, or was it adding more additional complexity? The third thing we really wanted to validate was, are they able to locate this data faster? The fourth thing we wanted to measure is, are there fewer inaccuracies post-submission? And last, we really wanted to collect the data that we were able to give them, and were we actually giving them the data that they wanted to see and the data that was important for them to get that at-a-glance data of their patients. So do you know from the start which metrics matter most to your stakeholders? That's a question I leave to you. And when I say stakeholders, I'm meaning this ecosystem. Like, are you taking into consideration the MDS nurses and maybe the regional managers or the leadership team? What are those metrics, and how can you align what's most important to them? Okay, so when integrating AI into the workflows, it's easy for us to focus on getting the data right, on training the model correctly, and on generating the best outputs that we can. And this is, of course, really essential and really crucial. But a moment is often overlooked, and that is a moment that's valuable for us as UXs, and it's that moment of decision making. So very quickly, this is a really cool framework that Raina Bailey shared with me during Ladies at UX talk here in Atlanta. And I thought it was great, but it really does emphasize this importance of how AI works. Very simply, we have instructions and we have data. So in our case, it was these clinical records. We have machine learning. So this is sometimes referred to as the black box because it gathers these instructions and this data and it outputs the result. So the result in our case was this resident summary. And then with that output, normally nurses or your stakeholders are expected to take action. So here's where there's a UX and UI opportunity, and it's adding a deliberate step. And that step is that decision-making process and making it very intentional in our designs. So here we added a flag or approve button so that the nurses wouldn't be left with this uncertainty and they would be able to validate the data very quickly. So if something looked off, if something wasn't right, if something wasn't coordinating with what they were expecting or their intuition was telling them, they were able to relay this to us. So it really, adding this decision-making feature really gives nurses clarity and control of their workflow. So do your designs support or undermine users' confidence at critical decision points? That's my question. Okay, next one is ground and story. So as we finished our pilot study, it was great because our clients actually saw the impact and they saw the good news that nurses were using this MDS resident summary, that they were enjoying it, and that we were able to add some of the data points that were missing from the original start of the pilot study. And they wanted to expand the pilot to a bigger team. So this meant 20 nurses over 3 facilities, all within the same state. And we really wanted to share this information, right? Share that we had done well and what data points were showing, what data was showing us from their interactions. But it didn't land. So we were presenting data in a raw format we were maybe talking about insights in a way that was a little bit abstract, and we were assuming that the data spoke for itself. And here I want to bring to today someone I really love and admire, and I read a lot of her material, and her name is Brené Brown, and she has a really nice quote that says that storytelling is just data with a soul. So that gave us the opportunity to just add that little bit of soul into the way that we were relaying this information to the nurses. So we shifted our approach, and then we started um, not only talking about the data, but we were talking about the data within the context of their residents. We now, in this new pilot study, we were able to bring in some of the nurses and have them talk about their own experiences and show them how the tool had helped them in filling out their MDS forms. So are you just showing the data, or are you actually adding a little bit of soul into your data? Our last brick today is design or ensure lasting value. And the way we did that was to really make sure we during our pilot studies and during this process, we really designed with support in mind, and that ensures impact. So we came to the realization that when we were onboarding nurses, it was very important for us to make sure that they felt very supported throughout this process. So we designed 3 key touch points. The first one was the kickoff presentation, which we made very intentional, and we are adding these nurses to talk about their experience using the resident summary. The next thing is we designed a beautiful onboarding manual, which is a clear step-by-step guide for new users. And last, we decided to keep some of the pop-up surveys ongoing so that nurses, apart from flagging or approving the data, were also able to give us and reach out to us very quickly if they had any issues or if they had any pain points while using the software. So after the launch, how are you actually supporting the users in the real moments, especially when they need most help? Okay, so if today's presentation resonated with you, I invite you all to learn more about the work we do at Digital Scientist. I'm here today just as a messenger. This is really a team effort from the product team, from the experience team, from the design team, and from the product team. We all work together really wonderfully during this project. And it's the type of challenges we really enjoy. We love partnering with healthcare organizations to tackle those complex problems and really build meaningful solutions that hopefully center around the people we care for. So before I finish up, I want to really quickly come back to this image of the pool. And if you can, and if you're willing, I invite you to close your eyes. So imagine yourself as a small child again. You're standing at the edge of a big blue pool, but this time something's different. You're not pushed in from behind and experience this sudden change. Instead, someone's already in the water. Maybe they're smiling at you, they're giving you encouraging words. They reach their hands out. They maybe dip your toes into the water for a little bit. They speak to you gently and encourage you, and they move at your pace. You're still entering something new, but now it feels very different. You feel guided, you feel safe, and you feel respected. Okay, I want you to open up your eyes. That experience felt a lot different, right? It felt more dignified, it felt more human. And we do this for children. Why don't we do the same for healthcare professionals that are really looking out for the residents and the people that they're working for? Sometimes this lack of trust is really coming from not just the change, but the fact that they know that if they adopt change that isn't giving them the correct results, it's really going to impact their residents at the end of the day. So we're facing this immense change in technology. I think if all of us log into LinkedIn right now, you will be bombarded by AI. And AI is moving so fast, and especially generative AI is giving us results so quickly that companies, I feel this really immense pressure to move fast, to move forward, and that yesterday was already too late, right? So they all want to jump in because they feel that fear of being left behind. But they oftentimes rush. They forget to really integrate their stakeholders. They skip framing the real questions and the real problems that their stakeholders are having, and they neglect that data that would support them making this decision. So the bridge canvas for us was a result of what really helped us to bridge that gap between no trust to trust. And today I hope you walk away with this framework, but sorry, my throat is giving up on me. So today, I hope you walk away not only with this framework, but a mindset that AI can and should be introduced, but always with trust and with humans at the same time. Thank you.